Good evening, Radha. Good evening, all panelists and viewers. Today we are having a very interesting discussion on what the first year residents want to know. It's basically kind of handholding and training the fresh residents, people who join first year in both MS and DNB. This talk has been necessitated because a lot of people on LGS keep asking, I'm joining MS or I'm joining DNB, what should I do, what books to read, will I get cutting, when will I be able to do polycystectomy, will I get laparoscopic polycystectomy training. So these are all questions, and I think there is a lot of expectation from the students, and probably many of them get a little uncomfortable when their expectations are not met. So I thought it is better we have a session and tell them what is actually expected of them and what they need to do.
I can have full screen, Baskaran.
It is full screen.
No, you're not here.
Oh, okay, hold on.
If I can just slightly add to what you said, Baskaran, the title, because quite often the students say, what book should I read? How should my daily routine be? How should I carry on myself? Because I understand many places they are not primed, not told. They have to learn from the seniors. So this is the background. They are at sea. They don't know exactly what to do.
Is it okay now?
Yes, fine, fantastic.
Okay. To discuss what is expected of the residents and what they need to do and how they can learn and improve their surgical training to their satisfaction and to the satisfaction of the teachers. We have eminent panelists, and our panelists have come from very many parts of India, as the map shows here, and it's my privilege to introduce the panelist. Professor Abhay, I'm not sure whether he has joined. He is Professor of Surgery in St. G.S. Medical College in KM, Mumbai. He's a popular teacher.
Yeah, Professor Dalway is here, yes.
Yeah, excellent. Good evening. He's a very popular teacher, speaker. He is known for laparoscopic surgery and surgical gastroenterology teaching. He's been running a center of excellence in minimal access surgery in St. G.S. and KM since 2012, and he keeps running courses. Apart from surgery and other things, he's also very active in many professional bodies. He is currently the Vice President of Association of Surgeons of India. He is also an active office bearer in many other bodies, including IAGS, AMASI, etc. He has numerous publications. Welcome, Professor Abhay. Professor Ashok Kumar Puranik, I can see. He is Professor and HOD Department of Surgery at AIMS, Jodhpur. Prior to joining AIMS few years ago, he was in the Army Medical Corps, and he had an exemplary tenure as surgeons in very many capacities. He has had a fellowship in trauma surgery and surgical critical care at Monash University, Australia. He has numerous publications and he has written many chapters on trauma. Welcome, Puranik. Professor Davinder Verma is Professor of Surgery at Indira Gandhi Medical College, Shimla. He is already there. Welcome, Professor D.K. Verma. Professor C. Jairaj, I'm not sure whether he has joined. He is Professor and Head of the Department of General Surgery, and he is also the Academic Vice Principal, Andhra Medical College, Visakhapatnam. He is a qualified pediatric surgeon with MCH in pediatric surgery. He has 32 years of teaching experience, out of which 14 years he has been professor and training MS students. Professor Jitendra is Professor of Surgery, and he was former HOD and Medical Superintendent at Jawaharlal Nehru Institute of Medical Sciences in Fall. It used to be called RIMS, Regional Institute of Medical Sciences earlier. And he has had training in acute critical care, and he is instructor, and he regularly conducts acute critical care courses in Imphal and elsewhere. He is also active in regional ASI. Welcome, Professor Jitendra. It's my privilege to introduce Professor Vikram Khate. He is well known to all the surgeons. He is Professor of General and GI Surgery, JIPMER, Pondicherry. He is a Fellow of Royal College, American College of Surgery, and he also has a unique PhD in Surgical Gastroenterology. He was awarded the Distinguished DNB Teacher of Excellence Award in 2018. He is a senior examiner for intercollegiate MRCS examination. He is head of editorial board or member of many editorial boards, including WebMed for JA surgical procedures. He is very active in ASA and IISG. He was past president of IISG. He has multiple awards. He has given numerous orations. He has had multiple fellowships. He has more than 150 publications in national and international journals. He has authored 45 chapters, and he has also edited 2 books, which are shown here, Writing and Publishing Scientific Research Paper, and thesis writing for Masters and PhD program. Welcome, sir.
Thank you very much. Thank you.
So now let's start. So we are going to discuss what is the training which all of you are following in your various institutions, and what would you recommend to the surgeon residents to follow. Let's start with Professor Kate. Can you just tell us what is the philosophy, rationale, goals, and start and end points of surgical residency? People come with enormous amount of expectations. So I think we should be able to distinguish that our 3-year residency program is totally different from the 5-year residency program in the US. So when somebody finishes 5-year residency program in the US, he is expected to be an independent surgeon and able to do many things independently. So can you come on live and tell people what would be the philosophy of training for the 1st-year residents? Professor Kate.
Yeah, thank you very much. Philosophy of the training, when a person joins surgical residency in any center, whether it's a MS center or a DNB center, as you very rightly pointed out, they come through a very difficult competitive examination, and they achieve their goal of joining surgery, and they have a lot of expectations. So one of the expectations what they have is that they will have this subject at the top of their group of subjects. It's a niche subject for them, and they look forward to all the experts in that field. So that is what is the expectation, and they feel that once they go there, they will get trained, and when they come out of it after 3 years, they'll become a very good, qualified, learned surgeon, and maybe also a well-researched surgeon. That is what I feel that they have the goals. Rational at the end of, if you're asking at the end of 1st year, when they join, many of these expectations, they would like to fulfill in the form of the love of the subject. They want it to become more. Number 2, you can say that they would, of course, they have joined surgery, so they would like to see, assist, and do some part of the surgery. Number 3 will be that they will be very much looking forward to the management of patients with some degree of independence. Some degree, I'm not saying quite a lot of degree of independence because they are in 1st year, but some degree of independence in certain procedures after getting trained. Goal is, of course, to successfully complete the 1st year and then go into 2nd year. And the last point, what you mentioned, the start, I already told you, the end points of 1st year surgical residency is the conglomeration of all these points that they should actually, as I said, they will be having a love for the subject. That love for the subject has to increase. Whatever they had expectations, they have to be met. If not, it's more than that. At least it has to be met. Like if, as I said, if they have 100% expectation, it has to be 75% plus. And at the end of 1st year, they should be very happy to do that course in that center. That's the most important thing. That is what I feel is the most important philosophy also, that when they are doing work, they should, I personally feel that morning when the resident is going to the hospital for work, the resident should like going for doing that work, like to do that work. The day he feels that why I'm going, what is the problem, then actually the negativity starts. That is what I feel.
Okay, thank you. Professor Abhay, do you have goals in your institute? I mean, first year. I mean, many of us, when you undergo a course, before you start the course, they check our knowledge, skills, etc., etc. So there are boxes in which we tick. At the end of the course, they check again to see whether there is any significant improvement in the boxes we have ticked.
Yes, can I add one more point?
Yes, please.
Actually, one more
Yes,
important
Professor
point.
Kante.
Just that at the end of, not at the end of first year, at least in JIPMER, at the end of 4th month, what we have according to a schedule that they have to complete a research proposal, what we call it as protocol, and submit it for the dissertation. So that is what they do. And then they have the scientific committee meeting is actually completed at the end of 4th month. And later on, they'll have some time at the point of time, ethical committee meeting and the clearance. So once the ethical committee clearance comes, they start doing the thesis work. Yeah, thank you.
That is integral to MS degree.
Yeah.
And people in DNB also have similar projects.
Similar thing is there. Similar thing is there. There's a timeline, there's a cutoff. You have to do the submissions. Everywhere you have to submit a protocol for your thesis.
Okay. Let me ask Professor Abhay. What is your institution practice? What do you expect your students to be maybe after 6 months, 1 year? I mean, do you have goals? This is what they should reach?
See, I've been a postgraduate teacher for last 39 years, and I've seen a lot of change that has taken place in surgical residency. I can tell you during my time, we were really wanting to do surgery. Right now, the people who are entering the first year residency have already their set goal of doing super specialization in mind. That's point number one. So they may not be interested in learning dressings of wounds, etc., etc. That's the mindset. So I'll talk about what my institutional protocol is and my unit protocol is a little later.
Okay.
The second thing that I'm seeing is the effect of common entrance examination, where 75% of the candidates who come to my college are from outside the state of Maharashtra. There is a serious language barrier, and to communicate with the patients in a local language becomes extremely difficult for them. So they are in an unknown surroundings. They do not know the institutional protocols. They do not know the routine. And that's the basic barrier. So my responsibility as a PG teacher in the first 2 or 3 months is to see that this person gets acclimatized to the unit and the surrounding department. Also the counter departments like Department of Medicine, Gynecology, and make them comfortable. Because all through I'm seeing that there is a lot of, in 3 years, emotional exhaustion that takes place. There is depression in quite many, especially in the first 6 weeks of residency. There is no time to eat. The workload becomes too much, especially after coming out of residency, coming out of internship. And that is where you require to give them some sort of confidence, which is absolutely necessary. As Dr. Kate said, they come with enthusiasm to become surgeons. And if you do not, as a responsible person, give them that enthusiasm in the first 6 weeks or 2 months or so, real bad effects can take place on a given candidate. My institutional protocol is very, very simple. As soon as everybody joins, there are a lecture series which go on over a period of 6 weeks to make them comfortable. Take them around the entire hospital and the college building to show them the campus, how large it is, where are the different departments like blood bank, etc., which are extremely vital for knowledge of a person who has just joined in. And then unit-wise sit together and see to it that the immediate senior becomes a good friend of the immediate junior. That I feel is something which is really done in my institute, at least in my unit, and the things go quite well. This is the way we go about starting for a first year resident. And as Dr. Kate said, as they graduate to second year and third year, they are given more and more responsibility. I personally feel as soon as a surgeon is concerned, if the foundations are laid very strong right at the start, everything becomes quite simple in the next 2 years to go. So if a person does not know how to tie a knot, or a person does not know which needle to use, there is going to be a disease. And these are the foundations of dressing, bandages, which should be imbibed in a certain initial part of the staining. That is the way I train my people. Thank you.
Thank you. I'll get back to you. Yeah, I can see Professor Jitender. Jitender, welcome. Okay, let me ask you, what is your protocol in your institute? When somebody joins your institute, first year MS, do you have a system? Tell them what they are required to do. Do you have a pamphlet, or you attach one of the seniors to each junior? So what is your protocol? Professor Jitender. Professor Jitender is from Imphal.
Or he has to unmute himself.
Yeah. We can't hear you. Yeah, we can't hear you. No, we can't hear you. Let unmute. Radha, can you unmute his mic?
Can you hear me?
Yes, we can hear you now, loud and clear.
Okay, thank you so much for asking me to be in this panel discussion. My institute is quite young, but then we have started producing our own MS general surgery. And basically what I try is what I was taught. And actually, I do not know what is your opinion about my alma mater, PGIMR Chandigarh. And that's where I was met a surgeon out of nothing. And I try to impart my students the way we have a work culture when I was a student. And I still hope that there is a work culture in any institute when the teachers lovingly teach their student to become a great surgeon. In my institute, just like in my alma mater, my institute, when I was doing my MS, we divide the students and give them, assign them to some particular faculty members as their guides, and they are kept rotating for say 2 months, 2 months, 2 months. We have 4 units, and we send them to other super specialty like urology, then cardiothoracic, neurosurgery, plastic surgery, so that they get acclimatized, they get to know the various teachers. And just as other institutes does, 6 months is the time period by which they have to submit their thesis protocol. And after having a rotation of say around 10 months, then the students are fixed to their parent unit. And then we start try to get all the we have also like journal and seminars.
Yeah, I'll come to that. I'll come to that a little later. I just want, what is your approach to the first year residents? I mean, they come, in some institutions, they are thrown into the deep end of the pool right away. And within a week, they just don't know what hit them.
Okay.
Yeah. So you mollycoddle them, treat them with kid gloves, or you just treat them like anybody else?
Pardon?
Do you mollycoddle them, treat them with kid gloves? Gee, they are fresh. They do not know.
See, basically, right now, see, as per the government guideline, we have 50% from the central pool, and we have got students from 50% of the students are from my own state, that is Manipur. 50% is supposed to come whether it's from any part of India, and the students, some of the students, they are, they are so enthusiastic, they get to learn our language, which is not very difficult, I suppose, within a matter of a few months. And actually we encourage them to interact with the local people, to interact with the colleagues, to interact with the nurses, and then they get our language properly. And apart from that, we do not have any sort of courses for the language. Is it what you wanted me to know?
Yeah, I'll come back to you about further things. Professor DK, you are there.
Yeah.
So how do you treat the first years when they come to you?
when the PGs they come in as first year, you know, the entrance examination we are divided. The PGs are divided, few from the state quota and few from the all India seats. The all India seat people, they are from the different background, different states, different, and few are from the same college or from the other college in the Himachal Pradesh. Now, all this, their rationale, their goals, they say that all depends on how the PG seat they have achieved, whether they have come through, all of them come through NEET. But now I would like to categorize them into four categories. One is a candidate who is willing to do his MS and willing only to do MS because he wants to do MCH. He can't do without MS. This is one candidate. There is another candidate who is very clear that I'll do MS and I'll stay with MS. There is another one who has got the MS by virtue of default because he could not get anything else, so he joined. He is totally unwilling. And there is a fourth category. There is a student who is doing MS only because he's near DRs or they are having some corporate hospital or something. They just want degree for the name. Now, all of them have different approaches. As far as our approach to this thing is concerned, how we treat them, all of them, they come to the department. They're pooled in, initially in one unit with the head of the department, head of the department, and then they gave it to the different units. All the PGs, they are given orientation from the college itself for 2-3 days about the college campus, about the laboratories, about the working and all. And after that, they are shifted in the units and they start working directly under the control of second year PG and answerable to the registrar. And of course, all the consultants, they meet them, they encourage them to come with any problem, especially the persons who are from the outside the college, outside the state. If somebody is from the south, he has some language problem or something, we always encourage them, they can come. We always treat them like our kids, but after 4 p.m. or after the working hours. They are just like our sons and daughters, but during working hours, they are as good as any other PG.
Thank you. Okay. Dr. Puranik is there. Yeah. Dr. Puranik? Hello?
Can you hear me now? Yeah, okay.
I can hear you. Yeah. Puranik,
Okay.
I have one observation in that AIMS Jodhpur as a syllabus for MS. Now, I would like to know from you whether you have categorized it into first year. This is the goal for first years to learn. Do you have anything like that in AIMS Jodhpur?
Exactly. We do have. We are a pretty new institute, and just first batch has passed very recently. And I have received, every 6 months, we receive 4 to 5 candidates. And at the moment, I have 21 trainees under me. Like for the first year, we do inculcate and give them the basic sciences. We make them, we deliver lecture, we get them presented, the case presentation is there, the journal club is there, the symposium is there. So it is already structured, topics are given, almost 3 months of topics is already organized, and every 3 months it is reviewed. So we do have a kind of plan for them, and everything goes date-wise. Like previous professors have already mentioned that they have to submit the thesis by 6 months' time, like that. In a PG teaching, I'm there for last 10 years, but though I do have a lot of long years of clinical experience, 20 years of teaching experience. But with the PGs, the direct contact had been mentoring them and giving them the thesis subject had been last 10 years only. I found that people face problems of, I'll come to thesis later on. Let me talk from their first arrival. You know, we have to be a leader, and how we treat them the very first week or first day, that matters a lot. So please ensure when you receive your trainees, do spend a time with them. Do tell them what is expected from them and what we are going to do, like that. And we do receive them with a lot of warmth and care. I do take care of, let me tell you, I prepare a thesis topic already in my mind. Okay, these are the general areas where I'm going to allot them the thesis, because I have seen by end of their 2 years and 2.5 years, everybody faces problem in completion of their thesis. So thesis is also almost decided, like within a week we allot them their respective guides, and even I work ahead for like my I'm next month I'm receiving 5 students. So in my mind I have already prepared those, what are the general areas where I'm going to allocate them. Of course they will work, what is the methodology, what is the sample size and all those things, but I know that what are the topics, general topics which is available to me, the amount of patients I have, so that they do not have difficulty in their sampling and their analysis and things like that. So coming back, that what I was trying to tell you, that as a mentor, we require a lot of introspection and training. They are going to emulate us. We have to be a leader. We have to be a kind of role model for them, and they do treat us as a role model. So how professional you are, how compassionate you are, how good you are in a communication, how human you are, what is your humility, what is your body language, whether you really take care of them, how they dress up, how, where they are staying, how do they eat, how they are spending their time, how they are integrating with each other. So right from the beginning, I tell them that, okay, you are in an institution and you are going to be a brand. So put a kind of a sense of pride and achievement in them. After all, they come through the lot of competition at national level. So I give them that pride. Okay, hold your head high, and you are not going to do anything which is unbecoming of a surgeon or unbecoming of a doctor. And I tell them that the quality I'm looking for in every student is altruism and the compassion, empathy, the communication skills, the technical skills, the clinical skills, whatever a good student is supposed to behave. I give them this at the very first meeting, that this is my expectations from you. And we lead by example, you know. So, and they look forward for us. So we are a new institute. We are taking baby steps. We have very few, like, as I said, I already have 21 trainees under me. And it's like a family affair. It's like a running a family. How good you run, how much warmth you put in, how approachable you are, how dependable you are, how you are ready to hold their hands in case of difficulty, you know. And they look forward. We have to give them the sense of
Okay.
they are going to achieve a lot.
Okay. Now, I want to know, do you have goals set? I mean, at the end of first year, you would have done this. Do you have anything like that?
Exactly. So we do have, like, I take 2 tests in first year. The first year I take, the first 6 months I take test on the basic science. They are also taught by symposium and case presentations in the journal club. We make them present also. And then after 6 months, I take another paper. There will be 2 papers after 1 year. That will be, one portion will be again a basic science in the whole of the gastrointestinal tract. So we have totally made, for those 3 years, they are going through the 6 tests. So initial first year, they are going to have 2 tests. First test will be basic science. Second test will be, first paper will be basic science, and second paper will be the GIT. And then I have made mandatory for everybody to go through ACLS course, ATLS course, critical care course. And I do promote them to kind of present papers and posters also. And our student has started going abroad this year. 4 of my students had gone to UK, their student conference, and they presented their papers.
Okay, thank you. I will now go on to the academics. Now, we all know there are many things which are involved in residency training. You need to give them knowledge. They are required to acquire skills. They are supposed to be good in interpersonal communication. And of course, the very fact that they are doctors and they are becoming surgeons means that they need to be involved in patient care, and it also includes case sheet writing. This, I presume, is a major bugbear with many of the PGs, because I think as an intern, I used to write case sheet. Now also I'm required to write case sheet. I think in many institutions, they are a little unhappy about it. Is Dr. Jairaj around? Professor Jairaj from Isaac? Okay, now let's go back. Dr. Abhay.
No, I think Dr. Jairaj is there. I can see him. he should unmute and talk.
Okay.
Dr. Jairaj, please unmute and talk. Unmute yourself. Somebody will have to unmute him. Who is the host?
Can you unmute? Because I don't have that power to unmute. Either the individual or Patta Radhakrishna.
Dr. Jairaj, please from the computer unmute yourself. There will be a
Yeah,
right
there's a button just come over your picture. Mute. Unmute. So you let it just click that unmute. Okay, till then, come on, let's move. We'll get Dr. Abhay. What is your plan for imparting knowledge to them in your institute? Obviously, you tell them the books. Yeah.
Baskaran, Dr. Jairaj is with you now.
Yeah. Dr. Jairaj?
Hello?
Yeah.
Can you hear me?
Welcome. Good evening and welcome.
Good evening, sir.
Yeah. We
I can't
would
hear
like
you
to know
much.
from you. We would like to know from you, how do you treat the first year students when they come to you? Do you give them any briefing? You tell them what is expected of them? Is there any kind of a introduction course? Do you run them through some basic things? What is your system in your hospital?
Hello?
Yeah. Can you hear it?
I can't
Professor
hear
Jairaj,
properly.
can you hear me?
Can you hear
We
me?
can hear you. Yeah, we can hear you. We can hear
But
you.
I can't hear you properly.
Hello?
I can't hear you.
Maybe you will adjust your speakers.
Can you hear me, sir? Can you hear me? My voice, Dr. Jai, I'm Dr. Patta Radhakrishna. Dr. Jairaj, can you hear my voice? Hello?
No, I think there's some communication problem. Professor
Hello?
Jairaj, can you hear it?
Yeah, I can hear you.
Okay, now I want to know from you,
Yes.
what is your college protocol when you receive the first year students? How do you treat them? We'll not go into the theory classes,
No, not that.
etc. But
that.
initially, what is your goal of treating them, training them initially?
So, as the first year students actually join our college, so the HOD first comes and we assemble, and first I give them an introductory lecture, not a lecture, introductory interaction rather. So I give them an introductory interaction and get familiar with them, because nowadays, because of the NEET exam, we get PGs from all over India, and because they have from different languages and from different states they come, so we have to get familiarized with them and their language and their whatever the college has taught them as undergraduates. So I start interacting with them for a few days, 2 to 3 days. I interact with them. I get to know them, their background of MBBS, whatever they have done, and where they have come from, and are they comfortable. And the other thing is, as other professors have put it, it is basically whether they have come by choice or by chance. So that also I just try to get information from them, because some people, as you said, as they slide, they just take the MS seat, and later we do know, as years go by, second year or third year they come, we know that these people are not actually interested. So the important thing is learning from that experience. As we get the new students, either by chance or by choice, they come. So once they have chosen general surgery as their specialty, so I try to impress upon them about surgery. So giving them the first the history of the surgery and what a surgeon holds, because it is quite surgery is centuries old, isn't it? So especially in India, where we have Susruta there, so I tell them all those things. And in our department, we have all the historical photos of Halsted or Bill Roth and everything. I just take them around. so that I'll just create that impression. The initial impression is the best impression, especially from the HOD, is the most important thing. So once I get to interact with them for 2 to 3 days, initially the students, and definitely those who have come by chance, definitely get an insight into the basic what is general surgery and how a general surgeon is and what is a surgical specialty itself. They'll come to understand. So I interact with them for the initial 2 to 3 days. Then later I interest all the faculty members, and slowly I introduce all of them at one session. And once they introduce the professors and the associate professors, they take over. So I give them each an initial basic foundation class. What we do is we try to give a basic foundation class. Like I take history of the surgery and other things which create interest in them and know about the background of surgery, so that they actually go into an experience of the real what a surgeon will become later, and so that they will be prepared mentally. So once that it is done, I go about and then allocate the professors and the associate professors with the simple basic topics. First, I tell them why. I also give them an insight as to how, and other professors have already told the attitude and the behavior and all those things. Definitely that they will definitely learn through our basic behavior and in our rounds, or as well as how do you interact with our colleagues. So they'll be keep learning, and when the right moment comes, like when they are getting angry on somebody or the patient or something, that is the time I stop them. Then I call them again. Then you now start interacting again. That is not the way you treat. So that is how, when the context comes, we try to, because you can't take a basic class on behavior and attitude and all that, because it comes through experience. And we are, as you said, we are the role models. We are supposed to be the role models, and how we behave, and how the assistant professors, the new assistant generation of assistant professors, we also tell them how to actually behave in front of these people, because that is the most important thing. And the other thing about the basic clinical skills, we also we try to reiterate that clinical skills are also important nowadays, because that is actually dying. The clinical skills.
We'll come to the skills separately.
Professor,
we'll come to the skills later. We'll come to the training. Okay. So basically, the residency training involves knowledge, skills, like you mentioned, interpersonal communications and patient care. So let's take one by one. The American College of Surgery has a program, surgery resident skills curriculum. So basically, they have a formalized training program, and everybody is expected to follow. Each institute which receives the students is expected to follow, and each student who is supposed to, so there is a procedure which the students are expected to go through. So there is a kind of advisory thing from ACS which teaches the students how to successfully navigate through the first year of residency. And they also have the same, they need to, so when they enter, so they go through a step and find out whether their basic level is there, and after they finish, the same things are tested again. So unless they show probably good satisfactory progress in all these same points, they probably will find it difficult to get into good unit subsequently. So basically this is the same what we decided, but in America they also talk about skills-based learning, improvement, and system-based practice apart from what we talked about. So the first thing which people ask in India is what books to read. So we all know books are the major source of knowledge, and apart from that, all these which have been here. So now let's give advice to the first year students. Let me ask Professor Abhay, what are the textbooks and manuals you would recommend your residents to possess and read?
Okay, I'll just go back a little. I have a different viewpoint as far as the American College of Surgeons is concerned. You have to realize that in America, everybody speaks one language, and that is English, including the patients and the teachers and the learners. So it becomes very easy for intercommunication skills. I know that there are Spanish, etc., but most of them know to speak and communicate in English. Very few. I have been to the United States, multiple universities at multiple times, and the common language is, in our country, the problem is though there is an official common language and a teaching language which is different from the official common language, there are many other languages which exist from where we get these patients. So I would suggest that any textbook or manual is okay. In my institute, we have a manual which is known as a resident manual, which becomes compulsory on the day of admission, is given to that and is supposed to read, because then what is available, what is not available, what is expected out of a resident, etc., is well given in that book. That is as far as the etiquette, mannerism, patient communication, everything is covered in that textbook. The second, you are talking of knowledge. There are multiple textbooks and manuals which are available. In my own institute, we have 2 people who have written books on clinical examination, etc., which can be adhered to. That I think we leave it to individual candidate, and I should not be advertising a particular book or this. As your second statement is best book, and that is where I, as a boss, come into picture. Whether it is my associate professor, assistant professor, right down to the first year resident, there are only 2 words I can describe that will make a good surgeon out of them. Number 1 is to involve them in everything that you do. Right from your own dressing, walking in the ward, talking to the patient, these are all indirect knowledge skills that the person is going to follow. And second is, if somebody has done well, inspire that person. So these 2 words are very important in my life as a teacher. Involve and inspire are the 2 things with the patient, is what according to me is the best textbooks. Clinical methods, examination, case discussion, ward rounds are a routine. I don't think much can be, but what is important for a first year resident is to know the logic behind the boss's thinking. Sometimes you have situation where the boss, who's the professor, will not agree with the associate professor in decision making. Why such a thing has happened should also be explained to the first year resident. Maybe in the long run, the professor may be wrong, but that also understanding should be there. For a first year, I'm sticking to first year because your topic is first year.
Yes, correct.
Conferences, Zoom meetings, dedicated websites, etc. I think at least in the first 6 months, when the person is just trying to stand on one's feet in the department and trying to learn surgery, attending conferences and hearing big lectures are not going to be of any help, because the foundation has to be very strong. Automatically these things will come. So I don't know what is this all knowing genie, the Google, that has become part and parcel of everybody's life, including a 6-year-old who is at present sitting at home and gaming around. So they are better teachers to us when it comes to Googling, etc., At least to me, I take help of my juniors in trying to find out some topics whenever I want. That is the way I would go about imparting knowledge to a first year resident in first 6 months. After 6 months, then comes your assessment of a person as to, is he on the right track? And what I mean by right track is he working properly? Is he having pride in the work that he is doing? Is he accountable? And is he a candidate for excellence? That is where after 6 months, the training starts. And you've got to be equal to everybody, but you can always identify a person who may be better than the others. And last thing, knowledge is also had after you finish your round, when your juniors, like senior residents, are taking round with the junior residents. That rapport becomes very, very important. If you do not realize that there is no rapport in between 2 people, you got to call them and see to it that all these issues are solved. That only will give a lot of confidence to the first year candidates, who will automatically then become a good second year candidate who will guide the first year candidate. That's the way I look at things.
Thank you. Excellent. You just mentioned that this topic discussion journal club was not really too useful for people in first year. Is there any role for surgical audit? Let me ask Puranik.
Okay, sir. Your first question, I'll come to your first question, like what book you recommend?
Yeah.
The book which I last, say, rather 10 years, I'm sticking to two books for the first year guys. First, and even if they read, even in the for 3 years, they can do well, is Love and Bailey and Farooq Hassan's. This Farooq Hassan's Operative Surgery and Love and Bailey. This two book I found is a very deadly combination. It covers almost all the things which is taught in the wards and in the operation theater, pre-operative preparation, post-operative complication, operative steps, and everything. So these are the two books which I recommend to all my trainees. And at the same time, when we give them the topic, the mentors are decided, and based on few topics, the mentors give them idea. Okay, you want to go for FNSC of the thyroid, you read Robbins and all those things. But as I said, I stick to these two books, and I found it very useful, including those 5 toppers in when I was in FMC. Those toppers were reading these two books as per my advice, whatever they say, and I keep advising this particular books. I'll just take back to previous speakers have given 2 points, which probably because of a large family they might be facing, like those language barrier and attitude problems like that. During my tenure in last 9-10 years, at least I have not found this kind of problems. Maybe when the family, the kind of this a student grows his number, I might face the problem. But in today's time, I find language is not a barrier. Usually, most of the people are okay, and there is always a person around to kind of translate the things, and you can always understand what is the patient's language like that. And what was the other question, sir?
I just want to ask you, do you have surgical audit in your unit, and how useful is it for the first years? Quickly, because we got lots of things to discuss.
Okay. We do have a kind of, every month there is a surgical audit. How many patients admitted, how many discharged, how many had wound complications, how many had stoma problems. Based on the system wise, it is analyzed. Every death is analyzed, and we try to plug that problems. Like I'll tell you, there are cases of diabetic foot, and they require amputation. And you thought that this can be managed conservatively, or with the conservative amputation, with the maybe raised amputation, arthropods, or things like that. And somebody lands up doing a BK amputation. So there are many mistakes at the same time. Those incidents, this falls in between incident reporting and surgical audit. With the surgical audit, I found 2-3 cases where they did not adhere to the advice given by the faculty, and it happened that the senior resident or the junior faculty taken a different kind of a decision. So you can always patch by adding an extra form. Okay, these 2 faculties are going to sign for this major amputations, and that particular problem is plugged. So a lot of things come out by doing regular surgical audits, especially as I said, the stoma problems, the wound infection, the abdominal closure method, like that. So you can change your tactics based on the feedback what you get on the surgical audit.
So it is definitely a learning object.
Certainly.
Okay, thank you. Now, may I ask Professor Kate, how should their surgical audit be done, keeping in mind these are first year students? Is Professor Kate?
Yeah.
Yes, please.
I'm not very sure whether first year students independently do a surgical audit. What we have is we have basically a monthly audit, and then we have a weekly audit in the units. Monthly audit is the department, and at the hospital level also we have audit at 1 or 2 months. Nowadays with COVID it's slightly delayed, but otherwise every 1 to 2 months we have it. So they are integrated with the unit, and the surgical audit is carried out with the unit. And this will include, as you said, as others have mentioned, that the morbidity, the mortality statistics, and then the do's and don'ts, what we learn from the individual cases. And personally, what I feel is that when a first year is there, I think a first year will learn maximum 80% off in the first 6 months from the residents around the first year. The residence can be in the form of a second year, can be in the form of third year, or we have at Jipmer and many places we have surgical, what do you call it, as senior residents. So these are the people actually who interact very closely with the first year, and the first year also interact with the interns here. So they themselves actually provide the learning, teaching, learning opportunities. So from the consultant, maybe when we have the grand rounds or 1 or 2 rounds, and as far as the teaching is concerned, what you mentioned in the previous slide, in the first year, how many opportunities they'll give. Unfortunately, we don't have a protected teaching time. I don't know about the other centers, but what happens is that if something needs to be done, patients, some investigation needs to be done, and that's the time the teaching class is there. It's the first year or the second year who loses that class. So maximum teaching they do is from being in the hospital, being in the wards, surrounded by their senior residents, including their co-PGs, from which they get it. And as far as surgical audit is concerned, as I said, morbidity, mortality statistics, and all around they learn from that. It's like
you can also use it to track what is the number of procedures each resident has according to his year.
Yeah, we can do. What you said is that nowadays we have e-logbook and logbooks and all. But as I said, somehow with the number of PGs that we get, and as I said, Jipmer, we have almost in the range of 60 PGs a year. So 60 PGs totally, like 20 each year. So 10 to 12 comes every 10 to 12 come every 6 months. So that what you're trying to say is that that logbook system is good, but overall with the limited surgical time instead of being inside the OT, I think the maximum learning is done now being outside the OT. But the training, I personally feel that wherever you get, you see, even if your senior is doing a dressing and you are assisting the dressing, that's one of the very good forms of getting the training. It's like that.
Thank you. Now this is what the residents are very earnest about: skills development. So we all know that we need to identify the required skill sets year-wise. First 6 months you should have basic suturing, dressing, etc., etc. Like you said, you don't have a dedicated training time, but some hospitals, I used to be in AFMC, we used to have dedicated training time for people to come and practice various things. And we need to increase the quality and quantity of skills training. Because like you said, nowadays there are lots of residents in each unit. It is not possible for people to have real operative exposure individually. So they can probably try it on other mannequins and other things. So simulation based is what is the flavor of the season. And we also need to have, like you mentioned, you have better interaction between one up, one down. So probably the teacher-student interaction also needs to be improved. So these are all well-established things. So now, how do we improve operative skills? Now, these are the common things everybody knows. Everybody needs to understand the science behind operation. If somebody is to do a hernia surgery, you should understand what is the science behind. And the art of surgery, he will have to learn from his masters. And everybody knows that every operation needs to be split into various small steps, and each step needs to be practiced. Now, residency is an excellent thing. Step 1, step 2, step 3 will be done by first year residents. Step 4, step 5 will be done by second year or third year. The boss may come in for step 8 and go away. 9, 10 will be done by somebody else. So this is a very excellent way of doing it. Let me ask Dr. D.K. Singh, how does he have the operative skills training in his institute? Professor D.K.
Yeah, thank you. The operative skill, as far as the first year residents are concerned, I think they learn from the second years only. They are not given any extra time or extra patient or extra this thing to learn. They learn what the second year does. He takes them along. Whatsoever he does, they learn from them. As far as the other residents are concerned, you are very right that it is all graduated. I mean, steps. Step 1, 2 will be done by someone else. Step 3 by someone else, like that. It's almost like that everywhere. Is how the surgery is learned, in my opinion. As far as first years are concerned, they simply are attached to the second year in our institute, in our college, and second year take them along for all the work. I mean, and then they give them the work if they think that he can handle it, or he is been trained or exposed enough to handle that. He gives them the work from beginning, from the suturing to the bandage to the then cut section, then to SPC to this chest tube drainage and all, like that they learn.
Thank you. So, by and large, I think all units have the same system. They have a buddy system. The first year learns from second year. When
Exactly.
he from second year, he teaches the first one. Okay. Now, Royal Colleges also have this system that to improve surgical training, they are emphasizing more on simulation. So now this is from my old college where I used to be in the faculty. So we have a surgical skills lab where we have everything for simple thing like for catheterization, suturing, knotting, and male catheterization or stomach care, for intubation. So you all have mannequins. So you have mannequins where you can make a cut and then the residents can learn to suture, or you can use a chest tube insertion mannequin. So you don't need to have patience for residents to practice. If you practice on this mannequin 20 times, he becomes an expert in doing a chest tube before he can try. Yes, Dr. DK.
Sir, I like to differ here. Because the training, that depends on which institute you are studying. I mean, you can categorize the institutes. One is state medical colleges. There also you have got two types of colleges. One college is there where the faculty is practicing. They don't give anything to the juniors. I'm sorry to say. The other state colleges where faculty is not practicing. The third is the institutes where all these facilities of simulation and mannequins are there. The fourth is, because we have taken the topic of DNB also. Fourth is DNB, mostly done in corporate hospitals. And I doubt whether a DNB student is allowed to do cut section there.
Yeah, they do. They do. At least, yeah.
It all depends where you are placed.
What I am trying to say, what people have also learned is that each institute nowadays has got so many postgraduate students, it is physically not possible to train them to the extent you would like. You have 20 people in your ward, and you can't expect all of them to do 3 catheterizations a day. It's not going to happen. 5 of them will do catheterization today, another will do next day. So instead, you have a mannequin on which they can do. So repetitively they can do, and they become expert before they can come out of that. Suturing. So you have mannequins. We have Professor Jairaj, who has got a surgical skills lab. Professor Jairaj, what is your experience in training your residents? Has it made any significant impact?
Okay, let me first put it this way. Nowadays, the present generation of students, they are not very keen on doing anything on inanimate objects. I hope you understand.
I do understand, but it is not correct for him to.
It is not. That's what.
Unless he has tried it on something else, at least he should have stitched pillows in his own house.
Yes, that's what. So we have to impress upon them, because what they think is, they feel as if when they join the first year, they feel as if they are supposed to do surgery on the live patient itself.
Yeah, sure.
Which actually is not the right procedure. So we all have to impress upon them, because once you open the skill lab and ask that fellow to go and suture, he'll just do it once. Then he says he might become an expert. He feels like that. So basically, it is our duty, whoever is actually in charge of the student or the senior resident or the. But I feel that the senior people have to go with the first year students, like the associate professor and professor, on their non-operating and non-OP days. That's what we try to do. We catch hold of the first year students who have all free days, like non-operating, non-OT days, non-operating and non-OP days. and we catch them, and two or three faculty members, the senior faculty members, not either professors or associate professors, because the rest of the people will be working in the wards. So we take them, once we take them, they know the importance of the situation, because the professor and the associates have come to a skill lab to teach them basic skills. So that is where I think we all have to impress upon the people who have just joined that everything is not learned on live patient and in the theater itself. And it is humanly impossible to cater to all these students, because I have an intake of 19 students per year. So it's around about 60 students we have. So it is humanly not impossible to actually give them cases in the OT. And the OT is a big, it will become a big mess, especially nowadays with the COVID. It's very difficult to actually even enter the OT without PP kits. So that is a different situation, of course. But basically, we do that, and we impress upon the students that for the first 2 to 3 months, what I tell the students and what I try to ask them to practice in all my units with the professors and associates, I give them feedback. Don't allow them to touch the patient, except for wound dressings under the guidance of a senior, wound dressings, because a simple dressing is an art, because the surgeon is generally identified by the dressing. That's what we have learned as in our generation. So basically it is a mark of the surgeon. So we should tell them this, make him do a dressing. That's a skill. It's an important skill. Or small local sutures in the ward itself, or in an emergency OT when they do slough excisions and all those things. So there we tell the assistant professors who's on duty to guide them properly. And basically what I want to reiterate here is, because for first 2 to 3 months, don't allow the patient, the first year postgraduates to come and operate on a live patient, because once they touch that tissue and get that feel of it, it is like it's an addiction. They just discard off these whatever skills lab is a useless thing for them. That's what I have actually learned from these present generation of students, because I have been a professor since 14 years and now I have HOD since 4 years. So I know all these students, I keep monitoring them, and I think that is the way. But basically we ask the patient, the students, under the guidance of senior professors and associate professors and senior assistant professors who are available on that very day, and all the people to guide them from morning. After the rounds is over, they all assemble by 11 o'clock until up till 1 to 2 before the afternoon session starts. They keep continually suturing. As you said, practice makes surgeon perfect. But the practice should start on internet things first, not on the patient. You can't experiment on the patient nowadays. It's very difficult. And they were talking about the corporate hospitals where the DNB is there. I've gone to a DNB exam which has been conducted recently. It was all something because of COVID examination. It was more like a COVID scenario examination. We had only slides and case scenarios being projected. A mannequin was the patient. So, this does not happen every time, but still, we should prepare the first year postgraduate should understand that handling the patient is a very, very important thing. And once you start handling the patient, you are not going to go back. That is where the important thing you have to impress, because they will never go back. They will not enter the skills lab again. They will just while away the time and go. So what I wanted is the seniors to actually guide them there. If an assistant professor is there, he's also of that. He's a young assistant professor, recently 2 to 3 years. So he's also of that same mindset. So he also will be like that. So I think it will be a waste of their precious time. So that is where I think the skills lab should start with the basic. And regarding the actual surgery procedure that you give them, that should be under supervision. Once you go in a skills lab, then you give them a skin, because the first thing you do is that only, just give him some skin sutures. So somebody, the assistant, has to supervise what you have done in the skills lab. The same thing applies here, and you impress upon him. So then I think slowly they will fall into place or into line, as this is the way that we have to get trained, and
and all these people, and so that they can gradually learn things slowly and efficiently, so that they will not forget what they learned in the first year. Because all of us remember that during our studying days, the first year subject that we have studied, clinics as well as the clinical the skills, are still with us. Only thing, we have just fine-tuned them over a period of time. So that is what we should know.
Yeah,
That
but
is
I
what I
wanted
think
to ask you,
most important.
have you found improvement in the surgical skills of your residents after practicing on these mannequins?
I can't hear you. What happened again? My thing.
How much improvement have you found in the residents' skills after practicing on this?
Please repeat it, sir. I just didn't get you.
Know how much improvement do you see in your residents after they practice in the lab?
Definitely there is a lot of improvement, sir. Definitely. After we give them the insight as to what is the tissue, how to hold it, and how to practice the suture, how to hold the handle, how to hold the needle, and the tissue, how do you lift it, the length you take, all that once you explain to them over these few classes that we take, definitely there is a lot of improvement from his initial to around 3 to 6 months of time. So that is the 6 months of time we give a basic first year postgraduate to hone his basic skills. Until then, you're not supposed to go give him whatever, go do that slough excision, go do this. That happens because of the workload that we have. It happens. All the first years are, especially in emergency, are the third room they are pushed, and that fellow will start scraping and it will bleed and he doesn't know what he's doing. That should be done under supervision, even on a live patient. So that is what I would like to say, because we should impress even on the junior faculty the importance of guiding a first year postgraduate during his initial years. Because once he comes into second year and third year, very little we can do, because he feels, as everyone, we also felt that at final year we are better than the boss or better than the assistant in certain things, with a little reservation, of course, but still that's what we feel. So that's where I would like to actually impress upon them that surgery is not basically learned in a few years. In 3 years, you are not going to become a master of surgery. You may get a degree, but not master of surgery. So we are still honing our skills. Still we are doing surgery. I feel like that, and I tell them also, still we commit some basic mistakes, which we feel like we should correct, and tell them that this is a mistake, and while you are doing also. So then even if you are telling them that you have committed a mistake, that will impress, especially as a senior, definitely that will impress upon them that surgery is not to be taken lightly. So that is how our skills lab basically works. So we have that open skill suturing, sir, and the rest is a lab mentor, and there's a lab training. Basically, we just teach them the basics.
I would like to tell many people that you may get companies like Ethicon to sponsor some of these labs, which you can establish in your thing. So they will give it free.
Because ours is a government institute. We had.
If you ask them, they'll give it. See,
yes, sir.
Etc. They will give. See, for example, these are the Beatles. I'll ask Dr.Abhay. Abhay is into lab training. How often do you use this? And I'm sure this is mandatory for people who want to do laparoscopic surgery. Can you just go on? What is your schedule like with the residents?
See, laparoscopic surgery is another ball game. Use of endotrainers, etc. The first thing that I try and do is explain to anybody who comes to me for laparoscopic training is however well the person may be trained in open surgery, laparoscopic surgery is a different ball game. And for that, I have to make them understand the basics. So I'll go back to a first year resident. Just now, Dr. Jairaj talked about holding an instrument, taking a stitch. All these basic things have to be taught to a first year resident. Now this, I always see it as everything to do with angles which are created between two instruments. How they are created, if you think about taking a stitch, the angles made by the two instruments, by which I mean the forceps and the needle holder, is about 45 to 60 degrees. Now that angle is the one which should be created by the endo trainer and the endo instruments to make things simpler. So again, I go back, just like we try and make foundations of open surgery very strong as far as the first year residents are concerned, by teaching them small things like skin suturing or maybe putting in a catheter, ICD, etc. Similar things have to be inculcated in a person who wants laparoscopic training in mind. That number one is how you are positioning the patient with respect to your trolley. The abdomen is the endo trainer. So where should be the object? There is a thing known as coaxial vision, etc., etc. I can't go into details. I can talk for 40 minutes on that. But I can only tell you that a good endo trainer is one which gives you manipulation angle of 45 to 60 degrees when your instrument's going, and an elevation angle of 20 to 30 degrees with the tissue that you are operating. If your endo trainer can give a candidate that, the work becomes really easy. And that's what I focus more on when I start using endo trainers. So let me go on record that not all endo trainers are good. Endo trainers, if they don't give these angles, are not good. You're showing me beetle, but I can poke a lot of holes in this beetle right now, but that's okay, not an issue. It's also important where the target tissue is kept to give you those angles. So yes, endo trainers form one important part of this. Only thing, what is added inside. So there is level of training as far as laparoscopy is concerned. Then what is as having the touch sensation, having the tissue sensation, then going on to suturing and knotting. So there are multiple things in laparoscopy as they are in open surgery. We start giving first year residents small things, then second year residents a little bigger thing, etc., etc. I would only say previously it used to be assist one, then do under supervision, and then do one independently. The scenario is changing because a lot of things are changing as far as operative work is concerned. More and more technology involvement is coming. We do not have we just have a 3-year curriculum, and becomes extremely difficult for a teacher, postgraduate teacher, to compress everything and put it on a candidate who is finishing the PG examination. So to me, laparoscopy becomes a part. If you ask me in the 3rd year, if I can manage to give a laparoscopic appendicectomy or cholecystectomy to a resident of mine, I will be very happy.
Excellent. Thank you. So basically, endo trainer is required. I think you need not buy an endo trainer. I remember I learned laparoscopy. I made my own endo trainer in a cardboard box.
No, I will come in here again. When I went for laparoscopic training for the first time to the US, I had gone for 3 months. First month, I was not allowed to enter the OT till I perfected knotting and suturing in one of the offices with an endo trainer. But the teacher had taken efforts to tell me the importance of angles that are created, how one should port and use of different openings in the endo trainer. That is the way you improve. So that is the real importance of endo trainer. Thank you.
Thank you. So what I'm trying to say is people can buy or make their own endo trainer. And nowadays they don't even have to buy a camera, or even if you want to buy a small camera also, it's available, or you can use a mobile and link it to your TV. So I would like to recommend to all residents who are interested in laparoscopy to make their own boxes, start working on it. Now, in India, we do not, like all the panelists have agreed that they have a kind of a basic idea what kind of training is to be given, but we don't have a measurable way to see the progress of the residents. There is a Delphi expert group for general surgery, which is working on this competence-based medical education. This apparently has been recommended by Medical Council of India. Now it's defunct. I'm not sure whether it is, but the Department of Surgery at EFMC is working on it. And if any of you are interested in contributing to this, then I'll ask them to get in touch with you. So once this is done, and eventually if everybody agrees, maybe this will become a kind of a framework for various institutions to follow. Now, the common problem which residents mentioned in various groups is that they are not getting enough cutting. Now, may I ask the panelists, let me ask Professor Khate, how can we improve the cutting chances under the given circumstances? We can't hear you. We can't hear you. We'll have to. This is a burning
Sorry, I
topic.
actually was
This is a burning topic.
unmuted.
Actually,
Yeah.
I'll also put it like this. There are two kinds people have said there are many kinds of students, 3 groups, 4 groups. But basically, there is a group which wants a unit which has a lot of cutting chances. There are some people who do not want a unit which has cutting chances so that they can sit and study for NEET exam for super specialty. Okay. Please, Professor Khate, how can we improve cutting chances for the residents? First year and then subsequently, just brief, few minutes.
Yeah, I'll be brief. Actually, I personally feel that the best cutting chances for a first year would be in the emergency setting. So if they're exposed to a lot of emergency setting, you get lots of patients. The number of people who are there are less. It's the residents practically who manage the emergency in our hospital completely under the supervision of the senior resident. So that is the best place for cutting as well as into the minor OT. So these are the two aspects where usually they will get chances to operate. And improvisation, as I said, it is very difficult with the number of PGs and the number of OTs which are there. So it all depends on patient load. So the patient load is good at a particular center. I think they should get a fair chance of doing some procedures under supervision. That is what I can expect a first year to do at the end of at the end of completion of a year. And I feel that just to enumerate what procedures, like many residents, if they're listening to this, that they should be able to do at the level of I can say I'm saying about across all the centers in India. At the end of 6 months to 8 months, if they can do a hernia reasonably fairly independently, I think that should be considered as a good goal for cutting. 6 to 8 months, I'm saying. At the end of 1 year, some emergency procedures like maybe feeding jejunostomy, appendix, maybe plus minus omentum patch closure. These are sort of procedures if they get hand of it. I think that's considered, that should be good. That is what I feel.
Thank you, Professor DK. How do you help your residents to improve their cutting chances?
See, I will very candid in saying that the cutting chances of first year resident depend on the adequacy or inadequacy of second year resident and how in good humor he keeps him or not. See what happens when anybody who goes into second year has gone through the first year also, that grilling and all. So what happens, the battered father becomes a battered baby becomes a battering father. That all depends on the attitude of the second year, whether he has learned from his residency of the first year how to behave with the person or not. Number one. Number two, I fully agree with Dr. Khate that the cutting chances will be improved in he will get only in emergency. Because of the number of PGs, they have increased so much, and the cutting chances will depend on the workload. If you are in an institution where workload is too much, you will get the cutting chances. If you are in an institution where workload is not there, you will not get the cutting chances. You are working in an hospital, in a college where there is a private practice going on. Nobody will allow you to touch the patient. So that all depends on the circumstances where you are working.
Thank you. Professor Jitendra, how do you train your residents and how can you improve their cutting chances? You said you follow PGA Chandigarh way of residency program. Professor Jitendra.
Can I come in here, Baskaran?
Yeah.
Can I come in?
Yeah, please.
One of the most important things is sacrifice by seniors that will give juniors cutting. I have sacrificed my laparoscopic hernia training so that my juniors can do open hernia surgery properly. This sort of things improves morale. And now what my unit people have started doing is they go in rotation for basic procedures. The person who is doing will be assisted by the person who has done the last hernia. So this is how they are rotating, and they are quite happy that everybody is getting equal cutting. The problem that has occurred in a particular teaching unit is that the bosses themselves are still learning other advanced laparoscopic procedures. They keep on doing those procedures, keeping the first year outside to run around and getting blood, etc., and keep on operating for 3.5, 4 hours. And that's how the cutting chances, 30 to 40% cutting chances go away. So I have my own likings in laparoscopic surgery, but somewhere down the line, my student should go out and be able to do a open hernia properly. That is what I personally feel. Because that person, if he goes and makes a mess outside, it is going to spoil my name. That's the way, at least in my institute, we work on this pattern. Of course, not all units are following it, but my unit is very, very strict about it. I do not mind sacrificing advanced laparoscopic surgery to giving a first year, maybe a hernia or a hydrocele to do.
Okay, thank you. Excellent. Basically, you need to have mature senior people. And so that is something which is important. Now, most
Can I just add a point? Actually, I have not mentioned that. Last few years, not last few years, you can say last almost 25 years, what we maintain in an elective OT is a scrub list, and which is reasonably followed quite strictly. So there in the scrub list is made by, actually in my unit, it's made by me only for the last 25 years. So you will know exactly from that who's supposed to do what, and you have an idea at what level people should do what. So that is actually, I feel, a good way of ensuring that it is independent of the equation between the residents.
So though you have an idea as to who is doing what, and you can keep rotating.
Yeah. As I said, that is how it is done. Mostly it is like if all the residents, mostly 80 to 90% of residents who are performing surgery in a hospital are assisted by the senior residents. So that is how the system goes. So the thing is, we put them as first year bar SR, like that in the sub list. And depending upon the type of operations, what they have done, we ascend them up according to the procedures. So that's why I said in 6 to 8 months, first year residents would have done up to the level of open hernia surgery. After that, they'll be doing slightly more operations. That is how it is carried out.
Yeah, scrub list
elective
is
OT. It's an elective OT. Yeah.
In many places like All India Institute, the scrub list is made by the senior resident. So he keeps rotating it. Okay.
Yeah, we keep it for faculty so that no influence is there at that level. So that, because you have to be in the good books of that person, and we don't write anybody's name in the scrub list. It is put as first year. So they do it by turns. If you have 2 first years in the unit, one person will do, next time will do. So no personal equation comes anywhere in play when the scrub list is.
Okay.
Basically,
so now let's come to the most important thing, the logbook which a resident is required to maintain.
Baskaran, Dr. Puranik wants to come in here. Ashok Puranik.
Yeah, I'm not on the screen.
Yeah,
Am I audible?
are on the screen.
Yeah, very much.
Okay, I'm on the screen. All right.
Yes,
You are Puranik.
Okay. Yeah. So, giving the opportunity of cutting, I found a very basic kind of observation that when all the trainees are in the flock system, they are into the groups. It doesn't matter whether they are on duty, off the duty. When they are in groups, they assist each other, and that's how they help each other and give opportunity to the junior also. At the same time, there's a lot of projects are going on. A lot of those thesis topics also goes hand by hand. Somebody is on E-tape, somebody is on a TAP versus TEP, somebody is on a diabetic foot amputations thing, somebody is on early laparoscopy on intestinal obstructions like thing. So they keep on they perform in a group. It has become a kind of a group dynamics. They work as a team now. So how your flocks are working together, that matters a lot. As I said, I don't have much of people at the moment, probably 21 odd people. So they always, I found them in our groups, 5, 6 people always. Even if I go in the night, I find, okay, you are not on duty, how come you are here? They said, I don't feel like, and this place is comfy, and we work together and we work with a tandem. So that's how they help each other. And rightly said by the other 2 professors that minor OT and the emergency is settings are the real place where they get a lot of cutting. Let me tell you, they start with skin biopsy, dermatological conditions, lipoma, sebaceous cyst, and other lymph node excisions and things like that. And that's how they get exposure. Incidentally, in my institute, we are lucky to have all kind of thing combined. Like we have a high fidelity trainer and lab trainer. We have mannequins. We conduct every 3 months workshop for the suturing and anastomosis. We have robots also. So they are having a very good exposure. Let me tell you, my third year residents who was really recently passed are competent enough to do perform advanced laparoscopic surgery, including hernia, laparoscopic jejunostomy, laparoscopic closure up perforation, and when I take a lot of senior residents from other hospital who have not been exposed to the laparoscopy, they have even able to pick up the laparoscopy. So it depends on the institution whether you are leading from the front or you are leading from the back. In first year, certainly you have to lead from the front. You have to take them along. You have to keep your flocks together and keep guiding them, keep motivating them. That's the mantra.
Thank you. May I now request Professor Khate to talk how to maintain the logbook, which is the most important thing for a resident. You're able to unmute.
Yeah, I have unmuted. A periodic check and a fixed routine, if it is done, then I think that's a good way of doing a logbook. Logbook, usually we have the columns that you have assistant, that you have performed under assistant, and that you have performed independently. And the consultant will usually sign it. So the procedures at the end of maybe every 2 monthly, it can be verified and it can be signed. So that is how it can be implemented. There is something called e-logbook, but I'm not familiar with that. That's also a very good way, and that's how some people have suggested about that.
Okay. Is Professor Jitendra around? No communication. Okay. Dr. Abhay, what is your institute system of logbook? Do you make the scrub list? Professor Khate makes the scrub list, so he knows which first year students are doing what. So at the end of the year, he will know, or 3 months later, he will know. Each person on average would have done 5 of each procedure. So what is the system in your institute?
The system is mandated by the Maharashtra University of Health Sciences that every candidate under the classifications that Dr. Khate talked about fills up the logbook from day 1, including suturing of skin. So at the end of the 3 years, 6 monthly review is taken of whether the logbooks are maintained, because the unit changes every 6 months. So at the end of that, the unit chief is supposed to see that the logbook has been filled by every resident properly. Usually this job is not done by the professor. It is done at the level of associate professor and assistant professor. And the thing goes on. The logbook has to be signed before the final form is signed, allowing the PG to appear for examination. So this is how my department works, which is mandated by the Maharashtra University of Health Sciences. Thank you.
Well, what is your action when you find a particular resident hasn't done enough?
That will differ from unit to unit. It's very difficult to actually look at the logbook that you have not done these cases enough, that case is enough. In fact, some of the assistant professors who have come from outside and joined us, I will not name whether it is MS or DNB, have not even done a single anastomosis. Now, this also, obviously, I don't know what that person had put in the logbook before clearing his examination. So we in our institute are very, very clear that every resident keeps on writing, and I'm quite sure the entire department sees to it that all the residents get good work to do.
Yeah, in KM that should not be a problem. The problem could be in many other hospitals where they don't have that kind of workload. Okay, so obviously logbook is necessary. Now there are many people who insist that a surgeon should maintain his own personal diary. Okay, may I ask Dr. Jayaraj whether such a thing is necessary or useful?
I mean, is it in context with the postgraduates?
Yeah, every surgeon from postgraduate. I remember I used to maintain a diary apart from the logbook where I
Yes.
would, what if I had made a mistake, what lesson I learned, what my boss told me, the correct way to do, etc., etc. So there will be a remark for each. See, each patient is a person who teaches you. Each surgery makes you a better surgeon.
Yes,
You
yes.
take, you learn, so you mark it.
Well, regarding the maintenance of the diary, it is not a mandatory thing in our setup, in our department, except for the logbook for postgraduates. But most of the senior residents or the new assistant professors who have joined and even associates, what they do is they keep track of what cases they are doing. And then they give a feedback as to how the procedure has gone. See, one thing is in an elective OT, I'm always present in the OT. In an elective OT, I don't go anywhere. I change the dress and monitor what is going on even in the third room. Basically, which we are saying the first year postgrad or the junior postgraduates will be there. But there, I think we are more required because I go into the third room more just to guide them because I'll be more free when I am not operating unless called for. So maintaining a diary, as you said, would be a very useful adjunctive for the logbook, so that if it's maintained properly, as you said, they should learn from the mistakes. If I have done a dressing and the dressing is okay, and or some I have done a suture, that is only making a list of the things that you have done, like in a logbook. But if a diary should actually, you should give back something to you, so that whether you have learned it properly or you have not learned it properly, but taking from the cue from you, well, maintaining a diary for all faculty members, everybody, I think it will be a useful adjunct for them to learn from what their mistakes, because everybody knows what mistakes they have committed. Nobody has to tell you that you have committed a mistake, especially being a surgeon, starting from the first year to the professor. So maybe diary, what you said, could be a useful adjunct to the logbook.
Yeah, I would think. Let's ask Professor Abhay as a point.
Okay, okay.
Yeah. See, personal diary is an excellent thing to do for self-assessment. It puts in self-discipline and also helps you in the later years of your life to tell you from novice how you have improved to becoming an expert in a particular procedure or procedures. At resident level, as they finish their PG, this data also becomes important for them in some of the universities abroad, which they ask you your experience and the data is in front of you. So it's just like a logbook, but this is a personal disciplined thing. And when you go ahead and become an established surgeon, and if you have a mindset of publications or something like that, the entire data is with you. So you can analyze your own data and go ahead and publish the thing. Thank you.
Yes,
thank you.
That's
yeah. Do the other panelists have anything to say on this?
Yeah, I have to say something.
Yeah. Yes, Professor DK.
Yeah. This personal diary, I strongly recommend that one should maintain a personal diary, not only the operative cases. I will recommend, what I recommend is, and I ask my PGs also, take a register. On the grand rounds, when third year or second years are being asked the questions, please start writing the questions and get their answers in your free time. Make a hard copy of that, because ultimately these are the questions and the queries which will be answered, which will be asked in the examination. And if a person does it for 3 years, I don't think he can never fail.
Thank you. Anybody else? Okay. Now, I mean, these are all things which you do. But then, like Professor DK said, then you sometimes have horses to whom you take to water, but can you make the horse to drink? Yeah. So I mean, surgery is a specialty which probably not everybody is interested when they come to it. They come to it because they didn't get dermatology or whatever. I'm just saying. Or there are maybe other reasons why they came to surgery. So how do you manage this?
Yeah, Dr. Puranik wants to answer. Ashok Puranik.
Yes.
Yeah, no, I was the previous point which I learned today is kind of making the scrubbing list. You know, so far I have not been making. From the today's this talk, I could really say I wish to really make this particular thing happen. Regarding the diary so far been replaced by your notes on your phones. So I do keep noting down the ideas which I get or some kind of spatial syndromes, answers like that. So that's the indirect form of maintaining a diary. But I can tell you the human brain with the 1,000 terabytes neurons, memory capacity, you do remember that where you got stuck in, how you came out and how to tackle this thing. Surgeons are very brilliant in remembering their faults, their difficulties, and everything lies in the memory. I think the human brain is the best diary one can say. Thank you.
Thank you. Okay, Professor DK.
Yeah.
You get some students who are not interested. Maybe Professor Kate or in AIMS Jodhpur, you probably do not get people getting into surgery which they did not want because they always the option of going to other specialties in some other hospital. So probably second rung institutes, you may have people who come to surgery even though they didn't like it. So you yourself mentioned, you classified your residents into 4 groups.
Yeah.
So how do you manage these people?
Ultimately, the horse has to take the water because if he is thirsty for so many years, he has to take water. I mean, that's my answer. Because you cannot keep him, ultimately, he's for 3 years with you. He develops some sort of interest, and what happens is most of them are either married or about to be married or in the middle age group, these persons who come from the state services. So they want to get out. Ultimately, they start reading something, if not everything, something. So they develop interest with the passage of time and they pass.
Thank you.
Yeah.
So now this is your problem. Many people feel that when people come to join MS, they are not interested. From day one, they are looking at post MS status. Professor Abhay made a mention about this. So Abhay, how do you manage such candidates?
See, you cannot prevent it. It is inevitable. All you can do, I'm telling you right now with specialty of urology, the candidate who comes to me with a aim of doing urology does not see a single urological procedure in the 3 years that the person works in my department. This is the truth. And obviously, I know that this candidate would not be really interested in doing general surgical procedures. That's a challenge in front of us. We have to try and mold them and not force them too much, because forcing them mentally tears them off. So try and involve them somewhere down the line. Talk to the urology boss. Send this person for 15 days just to, get freshened up and come back to work. These are some of the modalities that we practice in our this. But as you said, the previous slide, you can take the horse, but cannot make it drink. I also agree with Dr. Kumar that yes, that's the maximum you can do as a postgraduate teacher. More than that, I really don't know. I have not faced this situation where a postgraduate student has openly ever told me that I'm not going to do dressings. And the quality of dressings, etc., has not suffered. So give that person something nearby what he or she is going to do, and everything falls in place.
Okay. One major aspect, yes, Professor DK.
Yeah. You see, I want to make a comment. We, the general surgeons, are like infantry officers. We are away from the limelight, like which surrounds the cardiac surgeon or the neurosurgeons. But ultimately, we need to tell them that the wars are won on the ground, not in the air. So you have to inculcate the interest in the students in general surgery.
Yeah, no, we also had a panel discussion probably a month ago that general surgery still rules. We had general surgeons who are actually toppers in their cities.
No, I agree with Dr. Dalvi that
I think general surgeons will stay.
general surgeon will say, because Dr. Dalvi is very right that he only allows the laparoscopic surgery once he is clear that he knows the open surgery also.
No, laparoscopy surgery is a general surgeon's job. It is not necessarily a GI
No.
surgeon's thing.
Sir, they have started MCH in minimal access surgery now.
No, that is some problem.
They-
But nobody prevents you from doing minimal access surgery.
Yeah, that's true.
He is doing minimal access surgery. Everybody is doing. All general surgeons are doing. I don't
They are
think.
doing.
But basically,
You ask me,
excuse me, sir.
the real top laparoscopic surgeons are general surgeons. Yeah. Yes, Professor Jairaj. Dr. Jairaj, you can come. Hello. I think there's some problem with this net.
Baskaran, will you allow anybody from the floor now?
Yeah, sure. After this.
Are you done?
Yeah.
Hello?
Yeah.
Ilango, you
Hello?
have something? Yes, sir. Dr. Jairaj, please.
Yeah. What I would like to say here is laparoscopic surgery is an extension of general surgery. It started like that. So you should know basic open surgery, good open surgery, because when you fall in trouble, you are supposed to open. And I think all laparoscopic centers, when they initially started, all have good senior surgeons like us on the background. When they fall in trouble, that patient is transferred to the general surgeon who operates and opens and all that. So we should tell the younger generation, postgraduates and all that directly they cannot go into laparoscopic surgery. You can definitely improve on your skills as a laparoscopic surgeon and become a laparoscopic surgeon later. But the basic general surgical skill that you actually learn in your 3 years is the most important thing that you have to learn. Without that basic general knowledge skill, you can't become a skilled laparoscopic surgeon. That is what I feel, and generally that is, I think, is the right way of going about it.
I'm afraid not many people may agree on that, because you get a new breed of surgeons who start with a laparoscopic surgery only, and it's a totally different approach. It's like old timer used to do upper prostatectomy. After that, people started doing a TURP. So there's no conversion. I don't think anybody who does laparoscopic cholecystectomy will need to convert. Professor Abhay.
No, suppose there is a possibility, isn't it? There is a conversion rate.
Yeah.
There is a conversion rate. You can't laparoscopic cholecystectomies may not end up laparoscopic surgery.
I'm fine, thank you.
So you should always be in a position to actually complete the surgery. If there is any trouble like bleeding or some injury to some ducts and all that, you have to open up. Everybody cannot do. Only the high volume center or an expert laparoscopic surgeon, one or two can manage like that, the complications that occur during laparoscopic surgery. But most of them, we go into open. That is where we say lab bar open and go into it, isn't it? So, but basically what I'm telling you is the younger generation postgrads should know this, so that they can learn later the skills of laparoscopic surgery. If they become good laparoscopic surgeons, it's well and good. We are happy. But the basic thing is they should know open general surgery. Skilled, they should become a skilled open surgeon first before they go into laparoscopic surgery. Directly, you can't become a laparoscopic surgeon, isn't it? It's not there.
There are people who are becoming. Let me ask Professor Abhay. I'll tell you my own story later. Professor Abhay,
Okay.
yeah.
Almost all the general surgical procedures or intra-abdominal or intrathoracic procedures,
Okay.
the steps of the operation are same as that you do in laparoscopic surgery, except the surgery for hernia. And that's why I always say laparoscopic hernia repairs are advanced laparoscopic surgery and not basic laparoscopic surgery. That's point number one.
Yeah. Yes.
Point number two is, yes, the conversion rates for standardized operations, so-called in inverted commas basic, cholecystectomy and appendicectomy, are going down with improvement in skills of a general surgeon adapting to laparoscopy. That is where the problem is coming. That if at all I possibly do not show open cholecystectomy, a difficult cholecystectomy, what to do, what not to do to a younger surgeon, this person goes out as a trained laparoscopic surgeon, performs cholecystectomy, and then has to convert something he does not know what to do. Now,
Yes.
these are the points which have to be inculcated in the residents in general, right from the first year that we are discussing. That just because I can complete a difficult cholecystectomy does not mean you can do it. And that's a standard rule in my unit, at least, that if at all the gallbladder seems to be difficult, the residents will assist me or the associate professor in conversion to open surgery, but at no point I will endanger the patient's common bile duct. That's the way I teach my juniors, and I'm quite sure they have learned enough of open surgery. Again, I reiterate that laparoscopic hernia surgery, inguinal hernia surgery, is a different ball game, and one has to be extremely careful because complications of laparoscopic inguinal hernia surgery are much more disastrous as compared to open hernia surgery. That's the way I look at it. So I'm Baskaran midway. I learned open surgery. I converted myself to a laparoscopic surgeon with a strong base of open surgery. Unfortunately, this is dwindling over the years, and I say all the best to all the expert laparoscopic surgeons without background knowledge of open surgery.
True, sir. True, sir.
Yeah, Radha, do we have people?
Yeah, Ilango, you want to come in and make a comment?
Yeah, sir.
You can make any number of comments you want.
Sir. Thank you, sir. So I have a few questions. There are teachers here. We have a first year student, and I think the focus should be on how we encourage them to take their baby steps in surgery rather than teaching them about bigger things. So if the teachers can round with them and teach them how to handle a dressing, handle a good diagnosis, establish a diagnosis of an acute abdomen, evaluate those steps, establish and then make the decision towards surgery. That is probably what I feel is the key missing factor. Most of them lose their confidence at that point of time, and they literally lose themselves after some time. Once you lose a few of those key links, I think it is a big problem. For my training, I did my MS in 1997 to 2000 in Trivandrum. I never went with the idea of doing an appendicectomy. My idea was to do a good McBurney incision and leave things for my senior. And I must know when I should do a midline or a exploratory laparotomy in a patient with suspected acute appendicitis. That was my only goal. So I went there, when as long as my seniors were around, I will do a McBurney. I'll position, put all the sheets, everything, prepare everything for surgery, do the McBurney, expose the appendix. My only job was my pleasure was in pulling the appendix every time using the techniques that was described in Hamilton Bailey's emergency surgery. That was my key. I have never bothered about how I tie. It fell in place. By the third year of my training, I stopped doing acute appendicitis surgeries because I spent my time training my first year PGs. I said acute appendicitis must be operated on by a first year PG, and I as a final year PG will just stand by their side. There is a problem, I would do it. That was my approach. So I did not bother about knowing everything about appendicectomy. I did not describe anything. All I did was I learned how to expose. I learned when to extend the incision and stuff like that. It's very simple ones. And I learned how to close very well. This principle I used in MCH, I used in transplant surgery learning as well. Exposure of the vessels. For kidney transplants, I went there first week. I exposed the vessels very well. I connected the vein, one wall of the vein, then went to second wall, then did the artery, one wall, then the whole thing, the ureter half. Then when everything was falling in place, I developed the confidence to take the surgery forward. I feel if we list them and say, okay, from the first year, you're going to log in, this stuff, that stuff, I think it creates an overwhelming pressure on them. And I think most of them give up at that point. These students are young kids who have really got an interest in learning surgery. I think it is in those baby steps we have to correct them. Like they will make mistakes in their knottings or in their sutures. It's good to cut the suture and make them do it again. And as long as we have the confidence to stay there and correct their complications, which is the essential quality of a good surgical teacher. I believe a good surgical teacher stands there, sees a student makes a mistake, makes sure that the patient is safe, also guides the student to correct that step and then take them to the next. You have to build that confidence. So I think for a first year PG, even simple things like writing a good surgical consultation notes in a medical department consult is a good technique. I think the initial days, a surgical teacher who takes them through that will be remembered forever. So again, another thing which I used to do is I always ask the question, what is the next step? So yeah, of course, you have a patient with right iliac fossa pain. What next are you going to do? Are you going to do X-ray of the abdomen? Or are you going to now do an ultrasound? So I asked that question, what is the next step you're going to do? So that gives them the one step progress. Each time they do that one step very well, their confidence gradually increases. And I think then the decision-making skills comes back. I'm very happy to know that all of you are concentrating on the logbook, but I think personally, logbooks in India are a big farce. Unless you know very well each part of the surgery, your training is never going to be complete. That is not possible in 3 years. So if a person does a good Mercedes-Benz incision for a hepatectomy at the end of MS general surgery and is able to close it very well and safely, well, I'll be very happy. If he is able to mobilize the falciform ligament, I'm terribly happy. If he's able to close a perforation, if he's able to relieve a simple intestinal obstruction, he doesn't have to do a colectomy. Those techniques and skills will come with time. I think big surgeries or small surgeries done very well in succession. So that's one thing. I noted one more thing. So there is a comment on the chat page. What do you do with less cutting chances? So in US, the US training had a protocol. For every 55 liver transplants in the program makes them eligible to hold one fellow. So we had 110 livers. So we had 2 fellows. Programs which have 200 livers per year, they have 4 fellows. So it's equally divided. So anybody who crosses 45 is qualified, and then he can do another 5 or 10 as much as their case is available. But he cannot do 100. So the workload is really high. So why can't we, if the workload in the hospital is less, why can't we scale down the number of PGs and say, okay, we cannot provide adequate training to these postgraduates in this forum? Can't we even address that in our to the government?
If I can come in, Ilango, here, I think this is a controversial topic. This has been discussed number of times. It's not in our hands to reduce a governmental decision, so we can't. My only comment is in this regard. I have had occasions when I ask some surgical PG, he says, today is not my operating day. I'm going to the library. Then I'll see a dozen people sitting in the coffee shop chit-chatting, because half of them no operating day, other half operating day, but they are not there. Will the bosses know what is happening to them? Do the bosses know they are sitting idle or going to the coffee shop or going to the library? Are they monitored? Or do the bosses fix some job for them and make sure that they are monitored? I mean, that's the only worry for me, because there's so many postgraduates now. Who is where? Who is doing what? Nobody knows.
Sir,
Kate is not the right person, because he is in a system which is well oiled, and I think but he can start with that.
Sir,
do you monitor people who are not in the theater?
Yeah, Dr. DK. Yes,
Yeah.
Dr. DK.
Yeah, I have some jotted down some tips for the residents who are joining. For them, the best person to learn and understand is immediate seniors. Number 1, they should try to live as close to the hospital as possible if there is no hostel nearby, so that the time is very precious for them. They should build basic clinical and procedure skills. They should set a realistic expectation for family and friends about their availability, especially in the first year. Make sleep and wellness a priority. Set aside time to read and study about patients in the ward. Try to nurture the skills which you admire in your seniors, and don't follow the skills which you don't admire. Be kind to all hospital staff, especially the staff nurses, the paramedical staff. When you are unsure what to do, ask the colleagues or the paramedical staff. When in doubt, ask for help. And no question is too stupid. Keep on answering. keep on questioning, ask as many as possible, and never stop learning and improving. That's my tips to the viewers.
Thank you. Radha, shall we wind up? It's time.
No, but I wanted, I put up a question. At least I'll ask Dr. Ashok Puranik to respond to that.
Fine. Yeah, I think all these primary institutions, I think they have enough work. Anyway, ask Dr. Puranik.
Yeah, what was the question from Dr. Patta?
No. See, with so many students, firstly, one thing I realized that many a time, the HOD will not know the names of the postgraduates. Most of the time, with so many. So actually, what a person is doing when there is no operation theater that day, when there is no any academic rounds, and what is he up to? Because some people want to do personal work, private work, nobody knows where they're gone. There's no any accountability, and also whether they go to library or whatever. See, actually, freedom has become more and more now. Do you have a control on that?
Okay. Okay, I'm on the screen. Am I audible? Okay,
Yes,
I'll try to answer your question, sir. Really, I think this thing is happening where you have probably more than 30 or 40 trainees under you. Then only you don't remember the name. I think 20, 25 one can already always manage. It's better to give them a free time and inculcate going to the library is a very good habit. And off the duty, how do they really spend their time? I think we should give them the freedom, whatever they want to do and whatever life they want to lead. In between, as a HOD, I think we should be always involved into their wellness program. You know how, like somebody is sadly dressed, somebody is into drinking, somebody is depressed, somebody into substance abuse, like that thing. Those, these are the people who really require a special care by the HOD. Like there was a question that how to take the horse to the water, and you can't make the horse the water to drink. A lot of patience is required, lot of compassion. You have to really take care of those weaker students first. The clever one will manage themselves. So always target, I think as an HOD, if you're keeping an eye on your trainees, you will come to know that, okay, this is the boy who really requires help. And they take a time and they do better. Even who's the topper in the batch, they are basically they have the passion, they are following the HOD's expectations and the demand, and they do follow like HOD keeps giving, okay, you write this chapter, you present this, you prepare this, and that's how they become more wiser. So similarly, if the backbencher, the guy who's last in the line, is supported by our faculty or the HOD or some dedicated faculty, they can come up and you can certainly make them drink water. The other thing which I wanted to tell you, I may sound little kind of idealistic, but as I said, is a HOD or as a faculty, you have to lead from the front. You have to be a leader. You have to be a dreamer. Give them the dream. You have to be visionary. Give them the vision. I tell them how big magician you want to become, how big healer you want to become. This is the new kind of word you might find. I tell them that, okay, how big magician you want to become and how good healer you want to become, and the whole field is open for you to play. So they can become a scholar, they can become writer, they can become kind of a researcher, they can innovate. So, and you have to show them the future also, that, okay, these are the arena where you can go further, you can go abroad, you can specialize in so many other sub branches. So you have to put a dream into them and start working on them. You have to motivate them. You have to be a catalyst. You have to be kind of a real kind of putting vision into helping in their dream to come true. They can be certainly guided. Recently, I was examiner in King's Kalinga Medical College, and I was flabbergasted to see a lady topper answering every question. And if she failed to answer, I just gave some wild hint, and she used to suddenly catch. And then I asked the HOD, and he said that every day she spends, I give her a topic every day, and she presents kind of a topic every day for last 3 years. and that's how he groomed that particular student. So as I said, as a faculty, we have a tremendous role. What kind of because this people come from the competition. It's up to us that how we nurture them and what we want to make them. I know you in few institutions you have many trainees, and keeping the flock together is a real difficult task. But I think it can be still done. You can allocate their mentors and keeping a watch over them, providing those warmth and the personal care that will go a long way.
Thank you. Dr. DK has a point. Yes, please.
Last comment I want to make. First year residents are like fresh frozen plasma, which need to be taught by discipline, compassion, and empathy. That is the most requirement. That is required most for them.
I agree with Dr. Verma. Yeah.
That's all.
Any comments from anybody from the audience? You can please unmute and when all the seniors are around, please. Anyone? Dr. Anjali, you want to say something?
Sir, it was an excellent learning experience when all the motivators and stalwarts and role models are in front of you. At the end of the story, just I will highlight that again, when you come into the private practice, you again become the first year student, sir. That's all. It was a wonderful panel discussion, sir.
Okay.
Thank you.
Professor Balal, is your thing on the microphone? Professor Balal, if you can come in for a minute, because I don't see the microphone symbol. Yeah.
Connected to audio, sir.
No, because that audio symbol itself is not there.
Dr.Abhay, yes, please. Before Dr. Balal comes.
Since this discussion was basically aimed towards first year residents, and I'm quite sure on Facebook, lot many are listening.
Yes, sir, they are. Yes.
Dr. Devendra Kumar has perfectly jotted down 9 or 10 points which should be reheard again. They are very, very valid and important people, because when they come in to an institute from wherever they come in from, it is the professor or the head of the department's responsibility to, once they are allotted a particular unit, the unit head has to observe the body language very closely. You have a student who will overtly try and mix with the entire unit is likely to be a good student. But any change in behavior of this student should signal to you red flag that there is something going wrong. And this is a student who should be taken by the side, given confidence, and brought back from that depression that is happening. Because lot of frustrations are happening. Everybody has elaborated on the different types of frustrations that can occur in a resident doctor. The next thing I just want to say is you have to imbibe a culture in the first year itself. And the best way of imbibing culture to me is tell them to talk to the patient. My seniors have always told me that if you talk to the patient will give you the diagnosis in history itself without you even teaching the patient. So classical history taking while doing dressing have minimal pain to the patient. The patient start confiding in the junior most of the doctors, which is the victory to the unit chief. That is the second thing. And third, in summary, writing notes. This is one of the most important things I teach my junior most, so that a habit is inculcated. When that person becomes second year, he teaches the same thing to the detailed notes are real path to victory according to me. Years later, if a patient comes back to me with the operative notes, which I have operated maybe in year 2000, the details with which I exactly know what I had done. This sort of culture also should come in the first year residents so that everything becomes smooth. And lastly, what was this? First year residents and second year or third year residents, it's my unit policy that once I allot them that tomorrow you will be assisting X for a particular operation, then the person, reads that operation from a standard textbook, comes and starts assisting. It helps in two ways. Number one, the person learns faster. Number two is the person can question the operating surgeon as to why this step is being done, which is not described in that book. And then, the surgeons or these residents start improving. This also should be inculcated in the first year itself, that you will read and come. If the person sees a particular patient with appendicular lump who is under treatment, the person should quickly go read appendicular lump and come, so that the discussion becomes fruitful for that resident. Anyway, it was very nice discussing, Baskaran and Patta. Thank you so much for really having included me, because almost all others are HODs, and Kate sir, though I know he's very senior to me.
No.
So much. Thank you.
Ilango, what is your point?
And
The last, if I have the time.
One minute. Puranik sir, I think I met you in Jodhpur conference. I hope you remember me.
Yeah, sir. Please. Sure. Yeah. I don't forget people.
Yeah, Ilango.
Sir, the one last question I had was that, are these PGs sitting down and preparing for NEET super specialty because they never develop the confidence of handling these stuff, and they think if they go for a narrow specialty, probably they can cope? Is that the reason? Do you feel this? Do any of you feel like that? See, for a general surgeon, I think a wide range of knowledge is required, and the updating skill is you have to really, it's quite large. Is that the reason why the PGs feel that they should branch out into a specialty where their focus can be in a very small portion, so that they start preparing from their first year MS DNB days? Is that so?
It is, to me, a patient demand day by day. The patients want super specialists to treat them. The patient's knowledge is also increasing. Remember that. Today, if I, as a general surgeon, get a CA colon to operate, the first question the patient asks me is, what is your experience in oncosurgery? Automatically, not even surgical gastroenterologist, MCH, can dare to tell the patient that I am not an oncosurgeon. So this is the basic problem that has occurred in most of the PGs, taking a narrower and narrower route so that they can be recognized as the specialists in that particular field, so that ultimately in the long run, the patients stay with them. This is unfortunate truth. I may have done more Whipples than maybe a passing out surgical gastroenterologist today, or a surgical oncologist today, but the patient will still go to a surgical oncologist for a Whipples rather than come to me.
Yeah, Boston.
Yeah, I think we had an excellent interaction with all these.
Can I make a last comment?
Yes,
Can I make a last comment?
Yes, sir. Dr. Verma, yes.
Yeah. So I have read somewhere the concept of golden weekend to de-stress these first year residents, and it is somewhere in Alabama and US. What they do is they almost every alternate week, they send the resident, one resident is allowed to go and come back on Monday. And they are de-stressed, and it has improved the performance of the residents and known to decrease the stress also, which is very essential for the first year PGs. That's all I would say.
Yeah, but I remember the professors taking all of them for a dinner once in 2 weeks, or calling them home.
Yeah, I do it.
Does that happen?
Yeah. It's happening in Jodhpur. It's happening in Jodhpur.
Yeah, but with so many people, your drawing room will not be fit enough to accommodate so many.
No. People contribute. Larger contribution comes from the people who's got a birthday or anniversary like that. Coming back to that, people having tendency for post super specialization and NEET preparation. This particular attitude I found among the senior residents who are already passed and they come to the institution to earn their kind of subsistence and spend time by somehow and learn little bit of more laparoscopy, and they are focused for their super specialization. But I have not found this particular trend among people doing masters in surgery. The surgery students are not into this particular habit. Only the senior residents who are employed from outside, they have this particular tendency.
Thank you, sir.
Okay, I think we can wind up the show because you may have some other program, Radha. I sincerely thank all the panelists for taking time off and contributing so much to the discussion. And I hope it has benefited the residents who are watching it and who will be watching it later. Thank you so much. And it was a wonderful having all of you. Thank you very much.
Thank you.
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 Thank you.